Thank you again for joining us for this meeting. It's our monthly home care research meeting. We have been doing these meetings since last year, around September, and we've hosted quite a number of presenters. Researching the home care, it's not something that's quite popular, and it's a new space. And the sector itself is quite, fractured and not well organized in terms of research. So we are trying to work in partnership with the NIHR so that we, align the sector with opportunities that are coming with social care research. And, I'll start off with a few announcements before we actually get to the main presentation for this morning. We are starting a more structured community of practice. Melody is the one who is managing that, and we'll be sending invites to managers that have registered on our platform. And what we are expecting is that we should be able to share all opportunities that are coming from NIHR, opportunity to join research. We should be able to post them on that platform. And very soon we'll be launching a newsletter as well about researching the home care. And, Pristine Health Solutions as a home care provider itself, we've been fortunate that we were funded with NIHR to actually promote uptake of research across Greater Manchester. And the second announcement actually is a research fair that we are organizing on Friday in Middleton Shopping Mall between 10 a.m. and 2 p.m. It's an opportunity again to meet the community, share about research opportunities in the home care sector in the community. And there's also an opportunity to actually discuss about PPIE, which is going to be again the subject for this meeting this morning. And we have a task to come up with a toolkit for use in the home care sector, just to help carers and possibly the service users as well to understand what research is. So, written in simple terms. So that will be the focus of the research fair and workshop that we're going to have this Friday. So everyone is free to join in and participate. And the last one is actually there's a network opportunity from PAHN, that's Palliative Care Research Network, that's happening at University of Salford Media City campus on the 11th of March. That's in about 2 weeks' time. You need to register before the 1st of March. I would ask maybe Melo to post some of these opportunities on chat so that those who are interested can actually join in. It's a good opportunity to network and to know what's happening in terms of palliative care and end-of-life research. Now, before I take much of Miriam's time, I'm going to give you a chance to start the presentation. So Miriam is actually from CAHN, which is Caribbean African Health Network. They're doing amazing work when it comes to getting into those spaces where Black Africans and Caribbean people of Caribbean heritage are. So I'll not introduce. I'll not speak much of her. She'll introduce herself when she does the presentation. So Miriam, it's your turn. Thank you so much for joining us this morning.
Thank you so much. Thank you so much. I want to get you pronounce your name very well. Oh, is it Irvine? Yeah. Okay.
Yeah, it
Thank
is.
you so.
Yeah.
Thank you so much, and thank you, Melody, as well, and thank you for the team as well for having me to speak on this very important topic to amazing home carers and the wider team. We're always excited in CAHN to for any privilege to share what we do at CAHN and also explore how we can embed it into other organizations and the health system in general. So thank you so much again. Um, my name is Miriam Ejim. So I'm the Community Research Officer at CAHN and I'm based in Manchester. So CAHN is a UK-wide organization, but I'm based in Manchester. So I have my other colleagues in London as well. We do all things research. So from working with communities themselves to organizations, to universities, to other VCSC organizations as well. We collaborate together, we co-produce a lot of projects, and all of these, like you would see in my slides, we always like to say eradicate completely health inequality in our communities, but we know that of course is a step at a time, but we're getting there. So I'm going to share my slide if that's okay. I hope everyone is doing okay this morning.
Yes, thank you.
Okay. Yes, Nai. Thank you. Thank you again for having me and well done. I had the opportunity to look up the organization online and I think you guys are doing a brilliant job. So well done. So when I got the invitation, of course, I wanted, can you see my screen? Sorry.
Yes, we can.
Let me put it on
Yes.
slide share. Is it better now?
Yeah,
Yes,
yeah,
thank
good.
you.
Okay. So, like I said, when I got the opportunity to speak, and because public and patient engagement is what we do, most times in research because we're working with communities. I thought about applying it to what it would look like for the healthcare setting. So that's how I came about this topic, driving quality, because when we think about healthcare, we want to provide the best quality care for our clients, right? And we can only do that by collaborating with them by co-production, as you would see. Okay, so just a brief about ourselves, who we are. I mentioned it, but I just want to put it out there. Our mission is to end health inequalities and weather disparities for Caribbean and African people within a generation. And the vision that we have in CAN is, simply making sure that people from Caribbean and African communities and essentially underserved communities are treated fairly in health and social care. So not just in words, because we've heard a lot of things, but in real action. So we want to see, the actions of the things that we've been hearing for decades. So that's what we're trying to push forward. And we're doing this by making policies, the feeding into policies that do not disadvantage us as a community. We also check that the services that are available, be it health services, social care services, they actually work well for Black people. And then making sure that decisions don't just accidentally exclude us. Because I know I was working on, some projects earlier, which has to do with clinical trial, and we found out that all the trials that they did, for so many years excluded the Black community. And whereas we're still using those medications, and obviously they would not work for our community. So making sure that decisions are not made, excluding the Black people, and also ensuring equal access, respect and quality of care. We are pushing it out there so that they don't just know our story, they also act on it to give us equal access as well. Okay, so how do we do this? Our approach is that we work, like I said, collaboratively with the community, with structures, with systems, like we are here on this call, working with yourselves to make sure that we deliver, quality care. We champion and promote the work and asset of the community. So if there's a good thing happening in the community, we like to shout about it. We build and foster cross-sector partnerships. So, like I mentioned, we work with higher stakeholders, the government, the NHS, community organization, and then we like to keep this engagement going because we know that if it is sustainable, it can produce solutions and actually bridge the gap in our community. So why us? I mean, we saw the problem. We've been on and on again about poor access, poor experience, poor outcomes in our health. We learn about the structural racism that exists, the systemic discrimination, lack of trust. I mean, you could name it, lack of, poor engagement with services. Like, today, the focus we are tying down on research, and we can see that there's also lack of targeted research, right? And then a lot of things cut across different sections. So what we do is that we focus on, through research, we've seen that we have like main health streams that really adversely affect us as Black people. So the cardiovascular, the cancer, mental and emotional health, respiratory conditions, all the immunological conditions, reproductive and sexual health. Those are really, really important health streams to CAHN. And we work, our response also into health programs. So we do a lot of health literacy to make sure that our people are aware of conditions, and not just aware, they pick it way early in time, and then they are aware of where to go to, how to look for help, and how to shout out if they don't get the right help that they need. We also inform the media. You see out there, we're always promoting, health awareness of different topics, and we influence policies as well. So when we co-produce, we want to see that, okay, what we have come out with, the results of our co-production actually influences policies for our own good. And we call for support as well, because we are a charity organization as well. And then we educate, and then we do research. So research is a key area in everything that we do, because when we know, we are empowered to take the right step. To CAHN, like an organization, everything we're going to be talking about is linked to CAHN. So please permit me to talk about the work that we do with communities and stakeholders. We do that to champion culturally relevant approaches. So with everything, the services that we provide, we make sure that we embed our culture into it, because culture is very important for our people. And then we make sure that, even while we're passing the information about anything, be it a health research or a medical condition, we like to break it down to our communities that they understand. And with great understanding comes great engagement. Yeah, and that's what we've seen over time. Okay, so that's a bit about us. So we're going to get into it, but I'm conscious of time as well. We're thinking about driving quality through co-production. So just to put it out there, when we talk about, or when we hear co-production, what comes to mind? Anybody? I cannot really see any hands. You can unmute and just say
Working together.
something. Working together. Thank you. So co-production means working together. So I'm going to be coming from the research point of view and our practice here as CAHN, but I'll try to relate it back to the home care as much as possible. So at the end of the session, we should all understand what meaningful PPIE means, what it looks like in home care settings, and we just recognize how co-production improves the quality, safety, and outcomes that we get from our home care settings. And then we should be able to identify cultural responsive approaches to engagement. How do we engage with service users? We should also leave with some practical tools to embed PPI into our own services, because we're on about, I'm sure most of the things I'll be saying, we already know about it, but it's just taking those practical steps to applying the things that we already know or we're going to learn today. Okay, so PPIE, if you think of it, why it matters in home care, it increases diversity in care recipients. So if you engage more, the public and patients involvement, if you engage the public, there's tends to be increase in diversity in the care recipients. People from various background would be interested, and then it matters as well because we see persistent health inequalities in our care settings. I don't know, I didn't put up the slide where we have the different research about how the Black person is 3 times more likely, or sometimes 4 times more likely, to get a disease than their white counterparts and all of that. So if there is no PPI in healthcare, these inequalities will still be there and it will not change, right? It will not change. And then we know that CQC focus on person-centered care. And then we want to shift from doing for. So most times we want to do something for instead of doing with. Doing for, we are projecting what we think is right to the people, but what they perceive as right might not be what we are giving. So doing with will help us understand, okay, this is where this my client is at, and this is how I can help, or this is how I can work together with my clients to give them the best quality care that they need at that time. So home care is uniquely positioned to embed co-production because care happens in the person's own environment. So you're coming to the person's home environment, and you don't want to more like tell them what to do. You want to work with them and see and hear from them how they feel and what will work best for them. Obviously, if it is something that is dangerous, you know well to tell them, give them advice. But as much as possible, you want to work with them, to provide the best care that they need. Now, what we hear from our engagements with the community based on research and engagement ones is that there is lack of cultural understanding in care delivery. So it's a bit challenging because we live in a very, very diverse society. And then, you go into the work environment, you want to do your work, you want to meet up with time, you want to be fast and all of that. But we don't tend to pause and think about the cultural relevance of whatever care that we're delivering. Because most times, like I said before, what seems right for you might not seem right for the patient, even if it is right in all sense. So lack of cultural understanding in care delivery, mistrust due to historic or systemic inequities. We've seen that a lot now in our community, and so you need to try to build that relationship, not in a professional relationship with your clients still has the qualities of empathy, quality of trust, quality of understanding embedded in it. We also see from our engagement, we also see communication barriers. So a lot of things go in when you speak to someone, they don't just hear what you're saying, they hear the tone, they hear the message behind whatever you're trying to pass across to them. And then if there are any health literacy gaps, so you're using health jargons or some medical jargons that they do not understand, there are those gaps, and sometimes you might not come across as understanding to your clients. So you try as much as possible to break down communication barrier. Yeah, there might be language barrier, um, because we obviously we live in a society where we have a lot of people that are non-English speakers. But beyond that, when you try to bridge the gap for the language barrier, what I would say is breaking down, really, really complicated messages into simple English. Like if a child can understand you as a carer, then you've I would say you've provided um a care that can be acceptable. Because if you might think, oh, this person should already know these things, but if you look at community members, I know that we with research that we do a lot of jargons, a lot of medical jargons. So we try to see how to break it down that if a child can understand this particular research, then the community can understand that research. So when you think of that in that way, your tone will be taken into consideration, the assumptions will not be there. You'll be able to bridge any health literacy gaps that exist already. And then we also hear that it's important to handle our personal care with dignity and respect. I'm sure we know that the Black community, we are big about dignity and respect, and that should not be taken lightly. And also family involvement as central to care decisions. We see that most people feel safe when their family, is involved. Though there are some really exceptional cases, but most people would feel safe and say, "Oh, my brother or my sister or my partner or my loved one is around. I feel safe." So in like some of the discussions we have on maybe public health access, we hear things like we want to be heard before decisions are made about us. So people want to be sure that they were listened to and not just listening to the result or outcome of that listening session or conversation should result in the outcomes that they want to see, or when they see, they remember that, oh, I was listening to, and that will help to also build trust as well. Okay, so I'll go on to the risk of not engaging. So what do we see without meaningful KPI? We see lower satisfaction. So for example, a person receives care, but they don't feel happy or valued. They may say it's fine, but inside they feel unheard, right? They are not satisfied, even though the task was completed. So that's where PPIE comes in place. So they need to be carried along, like I said, to reduce any, lower satisfaction that might occur, or poor adherence to care plans. So without PPI, you would not understand. You might read the care plan, but to really understand it, you need to engage your clients. Reduce trust. If there is no engagement, there will be reduced trust. You have increased complaints. Oh, you think you're doing something right, you're working by the books, but your client is always complaining, right? Because they feel like they're not carried along, even if you're doing it by the books. Okay, today or at the beginning of the year, they said this was what was relevant to them. But mid-year, they feel like they want something different. But you are working by the books, and then you encounter, people complaining, and you're like, you refer back to the book, but the client is telling you something else. So that's why every step of the way you have to work with the clients, even if it's written on the book, you have to find yourself still checking in with them. Is this what you want at this particular time? Because your clients might need something else at that time, right? So to help to reduce inequalities, we need to engage in PPIE. So quality is not only clinical, it is rational as well. Okay, so clinical means, like I said, working by the books, medications are given correctly, personal care done, properly, notes completed accurately, all of those things are put in place. But relational means the person feels respected, right? The person feels safe speaking up about, their needs and their complaint. They feel understood because if you carry them along, there's a level of understanding that will be built over time, and then they feel empowered or involved to make decisions that will affect them as the receiver. Okay, so we also need to always remember that it's not just about what we do, it's about how people feel while we are doing it. How does my clients feel about what I'm doing? So that's involving them, and that's also co-production as well. Okay, so I'll just talk about. So these are the challenges. So I talked about some challenges that might exist in these kind of settings, right? And as much as we want to do our work, sometimes we are restricted, right? And then we struggle we struggle in between to really embed this PPIE we're talking about today. So one of it is addressing resource and time constraints. So the challenge might be engagements might feel like extra work. So if you want to engage, that's, to be fair, working with communities, you need to be patient. You need to have that passion to to care and to want to help them and want to make them feel better or feel loved or feel happy. And that takes some time as well. And if it doesn't have to be 100% at the beginning, it can come in little steps, right? You take the first step today, tomorrow. It's just that consistency that will lead to a greater result. So the solution I put down here is that you don't need to bring pull out new rules or anything. You can integrate it into what is already existing, right? The processes, the meetings, it's just having that touch of patience, involvement in whatever you're doing. So build that engagement through, like, for the managers and all, through your job descriptions, your KPIs. You allocate protected engagement time quarterly. So just to, introduce a structured what matters to you conversations, during the care plans review, what matters to you. So we want to hear from them. And like I said, PPIA does not have to be something that is difficult to do. If you think about it, just getting your patients along, your clients along, in every decision that is made. That is a level, that's the level of PPIE, right? Okay. So another area is closing skills and confidence gap. So the challenge might be staff lacking training in co-production method. Now, what we're doing now is what you're already doing monthly is a very brilliant action already taken. So have this conversation. So building engagement capacity, delivering short training sessions on the things that affect, or the challenges that have been recorded over time, where there's active listening, there's shared decision, you have people sharing their experiences, what they did, what happened, and how they were able to handle the situations. And then you include life, like I said, life experience of speakers in the staff training. Okay, um, based on the topic you're speaking about, okay, has anyone encountered, something like this in the workspace? How did you handle it? Just creating that environment where people can share and then build confidence. Because if you see that, oh, what I did the last time, is the right thing, it will build confidence next time when you're in that situation to take the initiative to do what you need to do. So also creating that simple engagement toolkits. Like I heard Urban talking about toolkits earlier. Creating just simple, it doesn't have to be complicated, just simple engagement toolkits, how to respond, what to say to the client, and all of that will really help. So when you feel confident as staff, you can even start up this conversation and engage rather than feeling, oh, I'm being forced to make sure I do this. No, it will come natural because you feel confidence, in that space. Okay, so another thing I'll talk about is overcoming cultural and communication barrier. So I've said earlier, our communities are diverse, and sometimes you might feel unheard or misunderstood. So we need to adopt a culturally responsive model. So, and this can only be gotten by understanding the clients that you're engaging with. I said earlier, using plain language communication. If there's any language barrier, you can offer translated materials if you have, capacity to do so. You can also engage with, trusted community intermediaries. So we talk about um, um, the faith leaders, right? You can not just recognize, them, but also you could even involve them, call them to, speak on something that's relevant to your clients, or, just that collaboration like you do with other organizations. You can also collaborate with faith leaders as well. So we also need to recognize the role of faith, family, and culture in our care decisions. So there are some persons that will say, oh, because of my belief, I do not do this, or I don't. We need to respect that. We need to respect the family decision as well, as long as it doesn't bring harm to your clients. The cultural aspect of things as well. You need to respect it, because most of the clients, or most of the people that live far from home, they like to stay in touch with their culture, so they don't lose that, cultural feel. So I put down here, like, creating a community advisory circle, because most times, when we have a disease condition prevalent in our community, we like to create advisory groups where people can come together and talk about the challenges, and then talk about not just challenges, the solutions as well, and also, start implementing those solutions. So if you think of it, in your organization, you can have people from, different background come together and say, okay, what we can maybe form an advisory group that's, would speak to the challenges, think about solutions, research, where can we get help and all of that, and then share it with the wider team to find solutions to whatever problem that is existing in the organization. Also, another challenge, we talk about shifting power dynamics. So this is all about co-production and engaging your clients or your service users. So the traditional provider-led culture. So we want to be the ones to always provide the care, which is why we are here anyways. But we need to know that the service users experiencing whatever they're experiencing are the experts. So they know how they're feeling. They know, there's always a story, behind it, all of that. We need to also acknowledge that. We need to include them in our decisions. Even if you have one person on the advisory group that is a client or a service user, it will give you a clear picture of your work from the client's point of view. So you can invite them, those that are really I think would be able to express themselves very well into to review policies. They could even be champions, as service users as well. So that's what we do. So I'm just speaking from my experience with the community as well. We have research ambassadors that we send into churches, we send into the community. So different groups, you hear of the Nigeria women group, you hear of the Ugandan men, all of those things. We try to find someone in those groups that we can kind of train to be an ambassador for research in those communities, because most times we feel like even if we get Africans to do a certain kind of research, we find that maybe 50% of them is just from all
Does
from West
anyone,
Africa.
let's say like 5 minutes for any questions, if anyone's got any. I'll just stop sharing. That was a lot of information, I know, and I will send the slide.
Okay. Hello, can you still hear me?
Yeah, we can hear. Sorry about that.
Oh, okay, that's fine. Sorry, I thought it was on this session. Okay. So I was saying, yeah, so we try to train ambassadors in different communities that would carry on the research awareness in those communities. So whenever we have research that has to do with, Black Africans, Black Caribbeans, and all, we have someone to pull in and say, okay, come, this is happening. Do you have an event that we can, attend, get involved and all of that? And then they serve as ambassadors because we've worked with them, we've built that trust, for the community, and then they can go back and, talk to their community, and we see a lot of responses using that method. So you can also introduce that to the home care system. Quality is co-created. You cannot do it one-sided because you are not seeing it from the client's view. So it is co-created. And then this has to come, so you have to model it from leadership. It has to come down, and they need to know that, okay, I am valuable even as a service user, and that would really, really improve the quality of care that you provide for them. So lastly, we're going to think about measuring what matters. So engagement outcomes are hard to quantify because you might say, oh, you're doing something for maybe a week and then you're not seeing any, improvements, and you might start getting discouraged and anything. So but we need to be intentional in developing those indicators that would track our progress. So let's say care plans, are they co-produced? The user satisfaction, how is it like? You need to set up indicators to check that as well. The complaints, have they reduced after engagement? You need to build indicators that will track all of those down. And then the feedback, because most times we we get feedback, but the action after that, is always lagging. So feedback to action turnaround time. If you can track that, then you can, quantify your engagement outcomes. So you can introduce, a dashboard that checks engagement activity, the insight you gathered, from the advisory group. What change did we implement this month? what outcomes can we observe from our service users and all of that. So this makes the process more measurable, and you're targeted. So at the end of the year, you can say, okay, we started off like this, but in the course of the year, this was the improvement that we gathered, and this is where we are at, and you will see a lot of improvement as well. So care planning, I mean, if you think of it, you have to produce, I'm sure you already do that, co-designing it with the client and with their families, incorporating all the cultural preferences, asking them what matters, not just not just asking, oh, how you feel, no, what's the matter? You ask them what matters to you, and when they know that they are listened to, their care, they will feel loved. They will feel like, okay, this care I'm receiving is quality because I'm listening. Some of them just want to be listened to be fair. They just want you to hear their own side of the story. They want to share. They don't, most times they don't really need, they know that you might not really be able to give them the immediate solution that they need, but just listening to them. And that's why PPIE actually takes time. But like I said, every step, taking it one step at a time, over time, it becomes easy, and you'll be able to embed it in your practices. Okay, I'm just looking at my notes. Can you still see my slides?
Yes.
Yeah.
Okay. So quality in home care is not only about compliance, right? It's about dignity. Let's remember, it's about trust as well, and it's about shared power. So co-production, it transforms services, just offering services into partnership. Care plans, it's transformed them into shared journeys. So you're not just looking at, oh, this is the care plan of my clients, but it's a shared journey because they were involved in it from the beginning. And then you yourself, you become a trusted ally to your clients. So that is what we want to get, from PPID. We want to drive this quality so that we can, our service, the service users will be the ones to give the feedback most times. So you would see the improvements, and you would see, that they would come back, happier. They would come back, really, really excited about the care that they are receiving going forward. So thank you so much for listening to me. And that's the end of my presentation. But before I end, there's something we usually have every Saturday. It's called the Health Hour. So it's still based on our trying to educate our community about health. So please feel free to join, because as I know, as a health provider as well, you would want to know the way different conditions affect ourselves as Black people in the UK. So this is where we try to break it down, and we have our Black doctors that come around to answer some questions. So please feel free to join us on Saturday. So I'll stop sharing now, and I'm happy to take questions.
Thank you so much, Miriam. Thank you for the presentation. And I think you've covered quite a very important topic, especially in our everyday work as care providers, and more important as well in carers and service users getting involved in research as well. So that's a very important topic. And before probably I ask my question, I'll probably ask others to share their questions first before. Is there anybody who wants to ask a question to Miriam? Right, I can see Tafara there. Yeah, Tafara, go ahead, please.
Okay, let me just put back my camera.
Right, and your voice is a bit faint as well.
I'm a bit faint. Can you hear me now?
I can hear you now. Yeah.
Okay. Yeah. Yes. Thank you, Miriam. Thank you, Ejim, for the opportunity for this great initiative where we were talking about minority groups and what CAHN is doing within our borders to improve health outcomes of minority groups. It's just a comment, just a general comment. I really liked there was a quote that you put at the end where you said quality is not clean, is not only clinical but relational. That really touched me, and it's very important for us to realize that because most of the times as care providers, we tend to be so interested in doing what is written in the care plans or what we're supposed to do at time X or at time Y, and rather being having a relationship with the patient with which we are providing care with. So it's a very important point which we need to all take back to wherever we are providing care to ensure that we provide the best quality of care to our patients. And lastly, I always say to all those I talk to about care is it's very important as a care provider to reflect, to always continuously reflect on your practice, reflect and see if you were on the other side, if you were the patient, how are you satisfied with the quality of care that is being provided? And if for any reasons you doubt it, then it means there's something which you should correct. So yeah, thank you very much, Miriam. Yeah.
Thank you so much, Tafara. Anybody else wants to ask a question or contribute? Right. So I think while people are still, gathering their thoughts, I'm gonna ask Miriam. So we've got a workshop coming up, and the aim of this workshop is really to gather around as carers, service users, if they are available as well. We are hoping that we'll be able to get one or two service users to be part of the team. The aim is to say what research is in the home care sector, and how do we actually get involved. So we are approaching co-production, and in that sense, and we want to be able to come up with probably a flyer that we'll be able to share with other home care providers. And I know you've already covered some of these things in your presentation, but what other things probably that you'd say, yeah, this will be quite important when it comes to actually having effective co-production ahead of such a workshop that we are arranging on Friday. Well, what are some of the things that we need to be quite watchful of, or probably emphasize on as we engage in this workshop?
Okay, thank you so much, Evan, for that question. So, like I mentioned before, co-production is, like we said, is doing things together. So, if we want to do a workshop, I would take example of what we usually do. So, we'll reach out to the community, and if we already have like a topic in mind, we'll ask them, okay, based on this topic, what's what is of what will be of great importance to you? Say, for example, clinical trials. You go to the community and just tell them, oh, we want to talk about clinical trials. And you hear questions, what is clinical trial? What do you mean by clinical trial? Am I going to die if I take part? So all of those reaction when you give them the topic is something you should take note of. And then your workshop will answer all of those questions. So they would feel carried along, when they see that, oh, you even attest from their feedback and you see that they really enjoyed it. So co-production is actually carrying the people that you're serving along, if I'll put it that way, in the planning, even the execution, and say, okay, because we always try to put the elements of lived experience in our workshops, our program, because we know that the power of whatever we do lies with the community members. So if they come, and then we know that again in our community, testimonials are really, really big, and people, if they hear it from someone that looks like them, they want to take part in research, right? So testimonials are a huge thing that we don't joke with testimonials in the community. So when I hear it from my friend, even if I don't understand it, I want to get involved because it is from my friend, right? So we use that a lot, and then we get people, to feel safe, first of all, because they see people that, that looks like them, that they are familiar with, and then we get them to really engage. And then we also do not compromise on appreciating our community members as well. If they come for a sit out, we try to give them either refreshments, or we just try to encourage them, because most of them will leave their work because they love what we do, they love research, they want to get involved. We don't just say, okay, thank you for coming. Most times, if it's an online session, we can say thank you for coming, and then smile about it. But if it's an in-person, they drove all the way from their houses, enter bus and
Okay.
all of that. When they come around, we want to say thank you with maybe an Amazon voucher, or maybe food, something to just get them, they feel excited to come next time, and then with that, we can not just having them to come, we can also pass on this knowledge to them, that when they go back home, they become champions of that particular thing we're trying to address at the workshop. If that answers your question.
Yeah, it does. It does. Thank you so much. Is there anybody else who want to ask?
Yes, please.
Sure.
Thank
Go on.
you, Miriam, for your presentation. It was quite informative. I've just got one or two questions. What research gaps remain in co-production within the home care sector as comparing to the hospital setting?
Compared to the hospital setting, interesting. I would say aftercare, is it aftercare now they call it? So from the hospital to the, or will I say recovery care, that
Okay.
is not so much in the hospital settings, because they just want to know that you're ready to be discharged, and after that, nobody checks up on you, nobody follows up again. But in the home care setting, I think we have that follow up. Even when they come back from the hospital, we have that follow up to be sure they are okay, even, till they get back to their normal, lifestyle. So I think that is the gap that exists in the hospital setting that I think can be found in the home care setting. So there's something we do in CAHN that we call it discharge services. So when people are discharged from the hospital, say they had like a broken leg and they are discharged, they're given a clutch to go home. If they contact our discharge services, we can, of course, if we have capacity to, we can send someone to, always go to visit them, to check up on their healing process, to check up on. So it's also that thing of building relationship with our community members. But when they see that, oh, they have a discharge services that will actually come to help them, some of them would not be able to go out to their normal shopping. We help them with their shopping and all of that. So that is not so much found in the hospital settings, but it can be in the home care settings very much.
Right. So
Thank
yeah,
you.
so with Silas there is actually participating in an internship program. So he's always looking
Okay.
for opportunities to come up with some research questions or something. I'm sure that's why he asked that question. Yeah. So is there anybody else who wants to ask something? Right. I'm gonna ask Miriam. So in terms of CAHN, I know, I mean, your portfolio is quite diverse. And we, as a home care organization that is with so much interest in research, we are always looking for first more research coming our way that is relevant to home care research, but also support when it comes to research workshops like the one that we are having on Friday. Sometimes you need people that are already been there, that are quite experienced in terms of managing such workshops. Do you have that kind of services or support that you do within communities, or within community sectors like ours? Yeah.
Is it to support workshops? That way.
Yeah, let's say it's a workshop like the one we're doing on Friday. Do you have any support services that
Yeah.
can get involved?
Yeah, we have lots of them. I mean, we have our there's a department in CAHN that's called delivery services. So we do a lot
Uh-huh.
of things. We have family, and we also have drop-in sessions as well. So there are also support sessions that people can join online from everywhere. We have the
Yeah.
family and advocacy session. So there they talk all things that that happens in the family, where you call childcare support. Maybe if you had any issue with the social services is addressed on that call. And then we have legal drop-ins where you come and ask ask questions on any legal issues, whether it's housing, immigration, and all of that. We support people as well. We also have a domestic abuse service as well, where people that have come out of or maybe are in that and wants to get out of it, we support them to get out of it as well. So we have a department that is dedicated for that, and we also have drop hubs. CAHN has community hubs. We have one in Gotin, one in Bolton. We have another one in Stockport. So they meet every week. So people go there, they get together, they meet, they do different activities. They also support and share, just creating that community hub where people can always go to on a weekly basis to share and all of that. So we also have a database that we are building. When we go to events, we are building a database where people that are interested in research can sign up for research. And then when we have any research upcoming for our community, we share it to them. And then if they are happy to, or if they meet the criteria, they could join as well. So we have all of these, and we're not just here in Manchester, also in London as well, and where we are represented. So we have a lot of street support, even digital inclusion. We also have that as well. So we have an office where we have laptops, phones, people can go in there. They want to maybe get registered with that SIM card, they want to do something online, their email, and they don't have, they're not digitally inclusive. You can come there and then we can walk them through and whatever issues that they have. So we have all of those support services. One of it definitely is a health hour that I shared. So it's also like a support session, because on there you can actually ask doctors questions, on the call, and they would give you answers.
All right, Miriam, thank you so much. I really appreciate for the response and comprehensive answer. I think we've just got 3 minutes left in the meeting. Unless somebody really wants to say something, I'll probably have to close this meeting. Is there anybody who wants to say something?
Thank you,
Right,
Miriam, for the
Melody.
presentation. Could you please share the last slide for Health Hour event? I think I can
Okay.
share that on our Homecare portal.
Okay, so should I send it via email then to you?
Yes, please.
Okay, I will do. Thank you.
My
Thank you
last
so much
question.
for having me. Sorry?
This one is just out of interest.
Okay.
If somebody is interested in research in the home care sector,
Mm-hmm.
how can they access or see what is going on?
So I'm
The
going to
research
drop,
that's active at the moment.
yeah. So I'm going to leave the link to our research interest form. I'm going to leave a link with Melody as well, and so she can share it. So we have a form where people that have interest in research can sign up, and then whenever any research is happening, or the ones that are happening at the moment, we share it to those database, and then you know what's happening. And if you want to get involved, you just reach out, or you reply whatever message we send across, and we know that yes, you're interested to join.
Thank you.
Yeah, you're welcome. Thank you so much for having me.
Miriam, we greatly appreciate for taking your time to come for this presentation and for the preparation, all the time that you put into this in preparation. We really appreciate. So this is the end of the meeting. We meet again next month on the last week of the month. I'm sure Melody will send some emails and links on how to participate. So thank you everyone who has just joined in this call. Thank you so much. Have a good day.
Thank you.
Thank you,
Have a good
everyone.
day, everyone. Yeah. Bye.
Bye.
Bye. Bye. Thank you.